So Dr. Shrey's topic is exploring choroidal and retinal angio architecture in dengue patients with associated dengue retinopathy using OCTA and CVI.
Good morning, everybody. So today I will be talking about the importance of choroidal vascular index and angio structure when we see patients with dengue retinopathy. So, move me. So dengue is a very prevalent disease, especially seen in the tropical climates. So Singapore and India are the two major areas where we find dengue, and so we get cases associated with it, that is dengue retinopathy. So this was a prospective study in which 18 patients were included, and 32 eyes of the 18 patients with positive NS1 antigen for dengue fever, and the mean age of the patient was 37.8 years. And the most important thing was that their platelet count was quite reduced, and it was around 76,000 plus minus 25,000 per microliter at the 7th day, that is the Nadir. And the follow-up was done as at 1 week, 1 month, and at the 6-month interval. So the main clinical features which we found that the best corrected visual acuity was better than 6/18 in 10 of the patients. Between 6/18 to 6/60 in 14 patients, and it was less than 6/60 in 8 patients. Posterior segment findings were retinal hemorrhages, cotton wool spots, grayish yellow foveal reflex, which can also be called as foveolitis, and 2 cases showed some vitreous cells. So OCT findings were conical foveal elevation, ISOS disruption, inner retinal hyperreflectivity, and inner retinal cystoid spaces were seen. On OCT angiography, we found flow deficit areas in superficial and deep capillary plexus. And in choroidal vascularity index, we found that it was decreased at the presentation in all the patients when we compared it to the normative data of 50 patients that we had. And it was persistent in few cases even after the recovery. So few of the cases, so here is the fundus which shows cotton wool spots along with the retinal hemorrhages. Right eye was affected more. So the similar OCT picture, you can see few cells also in the CME, and as you can see in the inside, there is a foveolitis which you can see on the side. This is the OCTA picture for the same patient, and as you can see, the dark blue areas, which are the flow void areas which we saw. There was, when we saw the patient on the follow-up, the patient started doing better, the hemorrhages were reduced, the cotton wool spots also went down. This is the same picture with fundus autofluorescence.
Carry on.
So the important thing is, like when we compared the patient on the OCTA, so we found this, that the eye, which was good, as you can see on the left side, the flow was around 51.7, while in the affected eye it was dropped to 47.3. One of the most important parameter that we saw was choroidal vascular index, and this was done by the binarization on ImageJ software. The ratio of the total choroidal area to the luminal area was calculated. So this is how this yellow marked area that you can see was the choroidal vascular index that we calculated. And this was the finding that we saw, that average CVI at the time of presentation was 67.23 in the affected eyes, while when we compared it to the normative data in the similar age group, so it ranged between 69 to 69.56 to 70.26. Patient with CME showed more decreased CVI, but which just had CME, they recovered better, while with the patient who had foveolitis and a picture with acute macular neuroretinopathy, they didn't recover better. They had some persistent visual problems that was approximately in 7 patients, and their choroidal vascular index was decreased even after the recovery at the 6th month. So CVI range also correlated with the flow deficit in the deep plexus in the OCT angiography. So the final conclusion that we came to was कि dengue retinopathy should be seriously looked on, and especially a patient who suffers with dengue and complains of vision should be referred to an ophthalmologist. And OCTA plays an important role in judging the outcome, because if we find flow deficit in the deep plexus is quite there, and if CVI is also affected, then the prognosis is guarded, and frequent follow-ups are warranted, and a guarded visual prognosis should be explained to the patient. Thank you.
So how does this help you to treat the patient? Did you treat your patient on the basis of these findings?
Ma'am, the treatment was basically based on, like, we started them on the topical steroid or oral steroid, and in one of the cases we even had to give the intravenous methylpred. So when we correlated it with the flow deficit areas on the OCT angio and the CVI, so this was we found it in the hindsight that if we would have treated the patient who had major flow deficit areas, and if we would have started the treatment with the heavy steroid dose, their recovery would have been better instead of just starting them on the topical steroids as we know been normally doing with the other patient. So this thing can help us to identify where we should be hammering the patient with a higher steroid dose in comparison to the patient where only the topical or minimal steroid can be started, and their recovery.
And the patients you said who had a persistent visual deficit with foveolitis,
Yes,
were these patients started on steroids? Because if they had been started, again, you have not, just to say that they had a persistent visual deficit, was that after high dose steroids?
Persistent visual deficit, when they came to us, few patients were at counting finger 3 meters. They recovered, but they recovered up to 6-9
and they were all given steroids early on. They were all given oral steroids.
Oral steroids were not started for all the patient. Initially only topical steroids were started, but after the first or second follow-up when patient were not responding well, so we started them on the oral steroid for the recovery. But the major conclusion that we get is, like, if we compare the OCT angio and if we compare the CVI, and we found that if we find that the flow deficit is too much, so the steroid should be started at the first go instead of waiting for the patient to.
Did you compare these patients, those who were treated and those who were not treated? Was there any difference in their visual acuity?
Any control study?
So we compared it with the normative data of the people, the normal, the patients who were not suffering from dengue retinopathy, but we didn't compare it to anybody who was not treated, because all the patients who came to the hospital, they were treated for the same. But when we compared, we found that on OCTA and CVI, the flow which we found, there was a difference between the normative patients and patients who were suffering. So the flow deficit was there actually present in the patients who were suffering. So it was, comparison was done with the normative data, but it was not done with the patients who were not treated.
So any other study you in your mind where there was a comparison done by some other person?
So there are studies on CVI. On dengue retinopathy, there is one paper by Agarwal et al. It was a case report which was reported. So they also mentioned that the patient, she was actually diagnosed by the ophthalmologist as to be a dengue patient, because she just came with a complaint of a viral fever for around last 5 or 6 days. Suddenly she had the complaints of diminution of vision. So they went with the NS1 antigen report, and they found that she was suffering from dengue. And in that they have mentioned that she had the foveolitis kind of picture, the acute macular neuroretinopathy picture. And they also have compared the flow deficit areas in OCTA-A. The CVI was not mentioned by them, the choroidal vascular index, but OCT angio was seen, but it was a single case report which they mentioned that flow deficit areas were there. But in other diseases, CVI has been done by Dr. Rupesh et al. And they have done an extensive studies on choroidal vascular index in other studies.
Did you find any retinal necrosis in any case?
No, sir.
Retinal necrosis?
No, sir.
No.
No, sir.
Any macular change post recovery on OCT?
Yes, sir. The ellipsoid zone disruption was seen post-recovery at the 6-month interval.
How many cases?
Sir, it was seen in 4 cases. So they, yes, sir. So they, on the Snellen's chart, they were not doing that bad, but their visual acuity, the subjective vision which they had, they complained about that even at the 6 months.
Did you test contrast sensitivity post-recovery patients?
No, sir. Sorry, sir. Contrast sensitivity was not done, sir.
Thank you.
And there were no cases of retinitis because post
Yes, sir. No, ma'am, that was not seen. But as in one of the paper, they have even mentioned about the developing of CNVM post dengue.
and none of these patients was diabetic because the findings were overlapping, the cortical spots and the hemorrhages.
No,
you
no,
said.
ma'am.
They were non-diabetic
no,
patients.
No, ma'am. None of the patient gave history of that.